Hello everyone. Today let's discuss on a very important question. They have asked many times as your short notes and also as your long notes in essay question in one of your previous year question paper, that is your acute myocarditis. I have taken this whole topic from our IJPP article volume 19th. Okay. Yes. So going to the topic proper. So as the name suggests, it is myocarditis. So TIS means itis means what? It is an inflammatory condition. So the definition according to your WHO is your inflammatory condition. So it is an inflammatory disease of heart muscle which is diagnosed. So that is diagnosed by your established histological, immunological, and your by immune histological evidence. Okay, so it is inflammatory disease of your heart which is diagnosed by histological, immunological and immune histological evidence. Yes, going on to your next topic, that is your epidemiology regarding this what is called myocarditis. So the annual incidence is 1 in 1 lakh population. Next, the peak age group in which your myocarditis most common is during your infancy and during the mid-teenage. Gender, male are more predominantly affected compared to the female population. So it is a male predominance. Yes. So this is 3 main points regarding the epidemiology of your myocarditis. Going into your etiology. So it can be either infectious or it can be due to non-infectious. So the most common cause of myocarditis among both infectious and non-infectious, the most common cause is your viral etiology is the most common cause. So viral is your most common cause. Among this viral, we have three most common virus that can cause your myocarditis are your first one is your Coxsackie B. Second one is your adenovirus, and third one is your human parvovirus B19. Okay, yes, these are the most 3 common viruses that can cause myocarditis in children. Other viruses that can cause are your hepatitis C, EB, HIV, herpes, your measles, mumps, rubella, varicella, and yellow fever virus, then your dengue virus. These are the other viruses that can also cause myocarditis. So other than viral etiology, your bacterial, rickettsial, your mycotic, protozoal and helminthic. These are the other causes that can also cause myocarditis. Okay. Next, coming to the non-infectious causes, first one is your toxins. So among toxins, the most common one or the one that is causing your myocarditis is your anthracycline. Second one is your hypersensitivity. Third one will be your systemic disease. This systemic disease, your most common systemic disease that is causing is your Kawasaki disease. That is the most common one that is causing a myocarditis in children. So this is the classification between infectious and your non-infectious agent that is causing myocarditis. Next, we'll go to our next subheading, that is our pathogenesis. So coming to the pathogenesis, first one is your stage 1 pathogenesis. So in stage 1, it is always an acute stage. In acute stage, there will be a viral invasion of your myocyte and multiplication. So in first stage, there is a acute viral invasion and multiplication. Okay, this stage, since it is an acute, this process or this invasion and multiplication will take place between 0 to 7 days. So here the virus will invade the myocyte So your virus will invade the myocyte, and that invasion leads to cell death and inflammation. Cell death can be either due to cell necrosis or it can be due to apoptotic process. So first stage, there will be a viral invasion of the myocyte that leads to your cell death and inflammation. Second stage here will be your subacute phase. So once your virus or some foreign body enters in your body, what will happen? There will be an immune response. That will happen in your subacute phase. In subacute phase, there will be your immune response. This will take place between 1 to 6 weeks. So in immune response, your T cell immune system. So your T cell immune system is activated. So the T cell immune system is getting activated. So once this T cell gets activated, this will attack both the virus and your myocyte, that is mainly your infected myocytes, by your immune mimicry mechanism. Okay, this is the mechanism how the T cell is attacking your body. So it will attack both the virus and your infected myocytes. Okay, yes. So once it attacks your virus and your infected myocyte, there will be two kind of reaction you can see here. So one can be your virus elimination, and there will be a decline in immune response, that is your inflammation will go down. So there is a decline in immune response, or there can be either virus elimination and presence of your immune response. So your immune response, that is there will be an ongoing inflammation will also be present. Supposing if first situation, there is a virus elimination and there is a decline in immune response, you can have two sets here. One, there will not be any injury. So once there is no injury, then it is called as your resolved myocarditis. Okay, or there can be injury and remodeling. So once there is injury and remodeling, it is called as, or the child will go into a chronic phase called as dilated cardiomyopathy, right? Yes. Next situation, that is there is a virus elimination, but there is ongoing inflammatory response, that is your inflammation is being present. In that situation, the child will develop what is called as inflammatory cardiomyopathy. In a chronic stage, inflammatory cardiomyopathy, right? So in a chronic stage, the child will go on to develop your dilated cardiomyopathy. Fine. Yes. So that is your stage 3. Stage 3 is your chronic phase. In chronic phase, the child will go to develop your dilated cardiomyopathy. Here the healing is mainly by fibrosis and remodeling. The healing is by fibrosis and remodeling, right? Yes. Sometimes the child can have persistence of virus also. So there can be a virus persistence, and inflammatory reaction will also be persistent. So sometimes there will be a persistence of virus and inflammation will be going on. So this is regarding your pathogenesis, right? Next subheading you have to write about clinical presentation. So here clinical presentation, the child can vary from asymptomatic stage to fulminancy, to a fulminant cardiac failure, right? Okay. So the major clinical manifestation, the major clinical presentation is R. First one, the child will present with the features of LV dysfunction. So when there is an LV, or there is left ventricular dysfunction, the child can have features of acute and or subacute features of heart failure. Next, second, the child can present with acute fulminant myocarditis. In acute fulminant myocarditis, the child will have severe congestive heart failure, or the child can present in shock or in multi-organ dysfunction syndrome. Fine. Third, the child can also have another presentation of like acute coronary syndrome. Acute coronary syndrome is most commonly it will present in adolescent age group. Here the child will present with the features of this thing, chest pain, presents as your chest pain with the okay, chest pain and dyspnea. Fourth, the child can present with sustained tachycardia. Child can go in for arrhythmia. So the child can have SVT or the child can have VT. Fifth, 8 to 10% of the children will have a sudden cardiac death. Right? These are the major clinical presentation of acute myocarditis. Next is your cardiac findings. So cardiac findings will be similar to that of your heart failure features. That is, the child will have your resting tachycardia or tachypnea. Second, the child can have features of shock, that is the CRT will be prolonged. Third, the child will be in a hypotensive state. Fourth, the child will have an elevated JVP. Fifth, the child can have cardiomegaly. Sixth, the child will have a soft S1 and variable S2, and S3 will be present, that is you will be hearing gallop. The child can have a low intensity systolic murmur because of your mitral regurgitation. So low intensity systolic murmur. So these are the features of what? Cardiac failure. The same thing will be present here. Next is your Sagar classification of myocarditis. So why I have brought this topic is this can be a separate 5-mark question also. So Sagar classification we have 3. One is without symptoms. Second one symptomatic. Third one histological and immunohistochemical features in EMB. EMB is nothing but your endomyocardial biopsy. So when the child is not having any symptoms, there is no symptom, then it is a case of possible myocarditis or possible it is a case of possible subclinical myocarditis. When do you call a possible subclinical myocarditis? That is when the child has one of these 3, that is which I am going to tell, one of the 3, that is the child is having something called positive biomarkers. Second, ECG abnormalities. This is ECG, okay? ECG abnormalities or cardiac dysfunction or abnormal cardiac function. So when the child has any one of these 3 without any symptoms, then you can call the child to have a possible subclinical myocarditis. Second, if the child is having the symptoms of your heart failure with one of these 3, then you can call the child to have a probable acute myocarditis. Fine? Yes. When the child is having a histological and immunohistochemical presence or features in your endomyocardial biopsy, then you call this child to have a definite acute myocarditis. So this is regarding your Sagar classification of myocarditis. Fine? Yes. Next subheading is your investigations. Coming to the investigation, we have first line and second line investigation. In first line investigation, everything must be done. When you suspect a child to have this is called myocarditis, then you have to do all your first line investigation. First one will be your acute phase proteins. Acute phase proteins or acute phase reactants. Acute phase reactants, we have already discussed this separately in another first video. Okay, so kindly go through that. In acute phase reactant, the child's ESR will be more than 30 millimeter mercury, or there will be elevation of CRP. Second, AST you have to do. AST is nothing but your aspartate aminotransferase. If the child's aspartate aminotransferase, that is AST level, will be elevated in the child with myocarditis. Right? So this AST is a sensitive marker. It is a sensitive marker in viral myocarditis. Next you have next investigation is your biomarkers, mainly your cardiac biomarkers. These are your TROP-T, second your TROP-I, third your CKMB, fourth BNP, fifth is your BNP. Okay. Fourth investigation is chest X-ray. In chest X-ray, you will be seeing the features of cardiomegaly, or you can visualize cardiomegaly. Not all the child who present with myocarditis will have cardiomegaly. Only a child who is having a subacute LV dysfunction. That is, a subacute LV dysfunction meaning the child is non-fulminant. Then you can see cardiomegaly, right? Yes. If the child is having or presenting with the features of arrhythmia or this one, what is it called? Acute coronary syndrome, then there won't be cardiomegaly. So other than your cardiomegaly, what other features the child can have in myocarditis? So other X-ray findings can be left atrial enlargement. Second will be your mild pericardial effusion can be present. Next, in ECG, coming to ECG or fifth investigation, ECG there will be many non-specific findings will be there in ECG, but triad of myocarditis in ECG is your sinus tachycardia. So triad of myocarditis in ECG features are sinus tachycardia, low voltage complex, mainly in your precordial leads. Low voltage complex in your precordial leads. And third one will be your ST and T changes. This is the triad of ECG changes in a child with myocarditis. Yes. Next investigation. These are the investigation that should be done mainly in when you suspect a child with myocarditis. Next is sixth investigation is your echo. In echo features you can look for or you will be seeing LV dilation, your ejection fraction, left ventricular ejection fraction will be decreased. Third, there can be mild pericardial effusion. Fourth will be regional wall motion abnormality. These are the four main echo findings that can be seen in myocarditis. Next, second line investigation. This second line investigation, this is not usually done. Fine. Yes. First one is your radionuclide imaging. Second one is your cardiac MRI. Cardiac MRI is being used nowadays mainly for your early diagnosis. So cardiac MRI is mainly used for early diagnosis. Second, for characterization of the pathology. Next, for performing guided endomyocardial biopsy. So these are the main things for which your cardiac MRI is useful. For performing guided endomyocardial biopsy. Next, third investigation, endomyocardial biopsy. This is not usually done, but this endomyocardial biopsy is the gold standard for diagnosing myocarditis. Fine. Yes, we have finished our investigation part. Next is our treatment part. Coming to the treatment part, treatment is always it is supportive management only. Here treatment part we have divided into two. One is for the stable child, another one is for unstable child. In stable child, we'll start on with our diuretics. So the most commonly used diuretics will be your furosemide. So nowadays they are using another drug, that is your torsemide. Why? Because this torsemide it reduces the biotransformation from myocarditis to DCM. That is meaning it prevents the remodeling. So So it reduces biotransformation from myocarditis to your dilated cardiomyopathy. Okay, next is your ACE inhibitors. So among your ACE inhibitors, the preferred one is your captopril. Why captopril is more preferred? Because of its short half-life and your it also has an additional antioxidant property. So we prefer captopril, right? So what are the hemodynamic effects of your ACE inhibitor? So hemodynamic effects are, everybody know, so it reduces afterload. So there will be a afterload reduction. Second, there will be an improving left ventricular ejection fraction. Third, it also helps in preventing cardiac remodeling. Right? These are the hemodynamic effects of your ACE inhibitors. Your digoxin should be withheld, or it is not indicated in a stable child with myocarditis. Third one is your, addition to this too, you can also use aldosterone antagonist. Your aldosterone antagonist is your spironolactone. Fourth choice is your beta blocker, or not choice, fourth drug, beta blockers. So among beta blockers, you use a cardioselective one. The drug of choice will be a carvedilol, right? This beta blocker should not be used, or it should be avoided in a child with fulminant myocarditis, decompensated heart failure, and in unstable child you should not use, or you should avoid beta blocker. Next, fifth one is this. Actually, this should be the first one. Rest. So rest in an acute stage, it is given for around 2 weeks, while physical activity is deferred. Physical activity is stopped for another 6 weeks. Right? This is regarding the treatment for stable child with myocarditis. Next, we'll see an unstable child, or a child with a hemodynamic compromise. Then you use, first one will be your inotropes, IV inotropes. So we have dobutamine and dopamine. Dobutamine is used for a preferred in normotensive child. It is preferred in normotensive child, while dopamine is preferred in hypotensive child. So this IV inotropes, the separate short notes for you in your university exam. I'll make a separate short notes on that also. Fine, right? Next is your vasodilators. That is, you use IV nitroprusside or IV nitroglycerin. This helps to offload your ventricle. Third one, IV infusion of your diuretics. Diuretic infusion. Along with this, you have to use ACE inhibitors. Next will be your antiarrhythmics if the child is having features of this arrhythmia. The drug of choice will be your amiodarone. Sixth one, your anticoagulant. When a child with severe LV dysfunction, you have to use this thing. What is it? Anticoagulant should also be used. Next, specific or a targeted therapy. First will be your antiviral. Antiviral is mainly used in an early phase of the disease, but it is not being used because before you diagnose the child is having viral myocarditis, before using this antiviral itself, the child will go on to a state of subacute state of your myocarditis. So this is not being much used. Second one, immunosuppressive is being used. Why? Because of a theory that due to pathogenesis we have read, no, it is because of immune mimicry. So because of the pathogenesis of immune mimicry, we use immunosuppressive agent, that is mainly your steroids. Prednisolone is being preferred here. Nowadays they use steroids mainly for specific diagnosis like child with, that is sarcoidosis with myocarditis, or if the child is having giant cell myocarditis. Third, virus negative myocarditis. Fourth, if the child is having a refractory myocarditis. Right? So before starting the steroids, you have to make sure that there is no active viral replication. So contraindication for using this is mainly when there is a viral multiplication. Okay, yes, this is about immunosuppressive. Third one is your immunomodulation. Immunomodulation is it is being preferred when the child or when the patient is having a antibody titers. When they have a high antibody titers, they are likely to respond to your immunomodulation. Immunomodulation is by using your IV. It is mainly used when they have a high antibody titers because they will respond well. The dosage of this is 1 gram per kg for about 12 hours. As infusion you should give for 2 days. For 2 consecutive days you have to use this. So this is regarding your acute. I have covered every topic of your, or every this thing of your acute myocarditis. Starting from definition, epidemiology, etiology, pathogenesis, your clinical presentation, then your investigation and treatment. This everything you have to cover in both in your short notes and in your essay as well. Fine. Yes. Thank you for your patience listening. Next video we will talk about refeeding syndrome, a very small topic. This is a very important topic. I have asked like 4 times in your previous 10-year question paper. When I have taken a look, they have asked around 4 times of this refeeding syndrome. So we'll talk about refeeding syndrome in our next video. Thank you.